quiz form. So if you want to answer, please shout out the answer when we ask the questions. Okay, so I have the first case here. This is a baby at birth, newborn, with this skin condition. Right, on the legs, you can see all these lacy, reticulate red patches on both legs and on the body as well, if you look closely, and it changes with temperature. So if it's cold, it will come up. If it's warm, the temperature, it will go away. Yeah, so what is your diagnosis? Very good, Dr. Leong. Cutis marmorata. All right, so this is very, very common. We see it a lot in neonatal skin. Most of the time, the neonatologists, the pediatricians, they will diagnose this condition. So it's very common in neonates and young infants. It's very transient. It means after a few days or a few weeks, it goes away, and you have it will change with temperature. So when it's cool, it comes up, and then when the baby warms up, it will go away or become less obvious, all right? And it presents with this bluish red, like reticulate marbling pattern, all right? Important, the child is very well, yeah? There's no fever, there's no poor feeding, there's no vomiting, the child is very well, yeah? Then you can call this cutis marmorata. And this is due to the contraction and dilation of these superficial blood vessels on the skin. What are some of the differential diagnoses? Yeah, sometimes if you see it on one leg only and it doesn't change with temperature, then you have to consider this condition cutis marmorata telangiectatica congenita. So you can see here on one leg, and some area they may have ulceration, yeah, or the skin is a bit thinner. So this is cutis marmorata telangiectatica congenita, so different, all right? Another differential is mottling, and this usually occurs when the baby is unwell. If the baby has fever, you can also see this reticulate rash, but everywhere, okay? So for cutis marmorata, you don't need to treat. Yeah, after a few weeks, after a few months, it will naturally go away. Okay, next case. You have this baby at birth, and you can see one side is a bit more red than the other side, right? So what is your diagnosis? Anybody? Okay. Okay, that is one of the differential, extensive port wine stain, but this one is called harlequin color change. Again, it's in a very, the baby is otherwise quite well, all right? It's transient, sometimes it's there for a few days and then it goes away, but sometimes can occur after a few weeks as well. So you can see that half of the body is red. Of course, a very large port wine stain can also present with that, but the port wine stain will not go away. This one, after a few days, yeah, it will come down and get better, so you can observe. And otherwise, baby is actually quite well, all right? So one of the differential is a port wine stain, and this, as I said, will not go away after a few days. It will still be there, all right? So for harlequin color change, there is no treatment required. Don't need to treat, just leave alone, all right? Okay, this one very common also. You see this newborn with a lump on the head. Otherwise, the child is quite well. The head may be a bit big. Yeah, so you can see this lump here. What is your diagnosis? So this is very common in the neonatal ward. Do you know this diagnosis? No? Okay, this is cephalohematoma. All right, cephalohematoma. So this occurs because there is a collection of blood that between the skull, the periosteum, and the skull, it collects there, and it's usually due to some birth trauma when baby is coming out during the birth. Yeah, you can see that the head is squeezed and you can get blood up here. Sometimes a little bit more larger, then we call it caput succedaneum. Caput succedaneum. But otherwise, baby is also quite well. However, because there's blood here, sometimes when it goes away, you can get jaundice because the red blood cells are broken down and some of these babies can come in after a few days with jaundice. Yeah. Otherwise, baby is actually quite well. Okay, next case. This is also very common. This is not seen at birth, but usually after a few days after birth, 3-day-old with this rash, and otherwise baby is very well. Yeah, you get this rash here. You can see red splotchy patches. Yeah, sometimes you can see some pustules. Yeah. So what is your diagnosis here? Yeah. Okay, so this is erythema toxicum neonatorum. All right. So again, very common. We don't know why it occurs. It's idiopathic. Usually, baby is very well, and it goes away after a few days. And you see this very splotchy patches. You can see macules. You can see sometimes pustules as well. And it occurs most often on the trunk, and can also affect the limbs and the face as well. But more common on the trunk, like in these pictures. And you usually see it in the not at birth, but after 3 to 4 days, they come in and they get this. Sometimes can be quite a lot, so the parents are a little bit worried. So, but baby is otherwise very well, and you don't need to treat. All right. There are some differential diagnoses which are a little bit more dangerous. If the baby is not so well, if the baby has fever, you have to sometimes think of these other conditions like neonatal herpes. But usually in herpes, you will see vesicles, all right? Vesicles. Impetigo, which is the second picture here. Yeah, you can see, again, baby may have fever, they may not be feeding well, maybe some vomiting. And you can see this, again, a very splotchy rash, but you can see it has this annular scaling. Yeah, annular scaling and very superficial erosions. Yeah, so you have to consider this in a not so well baby. This is impetigo. And then finally, you can also see candida, especially in the groin area. If you see satellite papules, you have to think of candida. Sometimes the mother may have candida in the vaginal tract and they can catch it from there. Okay, most times baby are also quite well, but sometimes baby can be quite sick, especially if the baby is premature. All right, so this is candidiasis, which we see sometimes in newborns as well. Okay, this is related to erythema toxicum. Again, 3-day-old. Usually they have darker skin. So like in Singapore, we see it more with the Malays and the Indians. Yeah, darker skin, and then they also get these small pustules. And then after a while, it becomes a little bit brown, a little bit of scaling. So what is your diagnosis here? So Dr. Leong knows everything. He's very, very clever. Okay, so this is transient neonatal pustular melanosis. All right. Okay, it's less common than erythema toxicum, but some people think that it's related, and we see this more in the darker skin babies. Okay. Again, it's benign, so baby is actually very well. Yeah. It can be from birth, so sometimes when they are born, you can see these vesicles and pustules, and there's a bit of redness at the bottom. After a few days, you can see it becomes more, the pustules go away and you see this peripheral scaling, and then you see a bit of hyperpigmentation, all right? So this is transient neonatal pustular melanosis. The baby is otherwise very well, so you don't have to treat, all right? The pigmentation may last for a few months and then it goes away on its own, all right? Again, the differential diagnoses are the same as for erythema toxicum. So you have erythema toxicum neonatorum. You have to think of herpes if baby is unwell, if there are blisters. Impetigo, again, you can see annular rash, as well as baby may have fever, and candidiasis as well. So this is, again, one of the differentials of transient neonatal pustular melanosis. If you're not sure, you can take swab, send for fungus. You can also take swab, send whether there's herpes or there's Staph aureus there, all right? But otherwise, baby is very well when they have transient neonatal pustular melanosis. Okay, again, quite common. I remember both my kids had it. You can see this little whitish spots. Usually, most babies have 1 or 2, but sometimes they may have more. Yeah, what's your diagnosis? Melia, very good. Okay, so again, it's very, very common. Sometimes they're at birth, sometimes you only notice it after a few days or a few weeks of life. Okay, so it's very common. You can see in 50% of newborns, and they are actually epidermal cysts. Okay, like adults, they have epidermal cysts. This is epidermal, small little epidermal cysts. If you take biopsy, you will see some keratin inside. They are usually very small and very pinpoint, and can occur most commonly on the face, but sometimes it's elsewhere on the body. You can see it sometimes on the palate here. Yeah, so we call this Epstein pearls. Yeah, again, babies otherwise very well, it will go away on its own. Sometimes you can see it on the gums as well. The gums. Of course, baby got no teeth, so these are the gums, and you can see it there as well, and we call it Bourne's nodules. Bourne's nodules, but they are all the same thing. They are all miliary. All right. It self-resolves after a few weeks, or sometimes may take a few months, but usually by 1 year of life, it does go away. All right. Sometimes parents might come in and say it doesn't look nice. You can actually prick it and express the keratin if they want it done, but usually we leave it alone. It will go away. All right. Okay, this is again quite common, but we see it mostly in darker skin babies, but sometimes also in Chinese babies. You can see this little yellowish little bumps around the nose area. It's what we call the seborrheic areas. All right, any idea what this is? Okay, so this is sebaceous hyperplasia. Okay, again, quite common, and it goes away on its own. And why this occurs? Because there is maternal hormones which make the sebaceous glands a bit more reactive, produce more, it gets blocked, and then you get this sebaceous hyperplasia. All right, usually you usually don't see at birth, but sometimes you can. But usually in the first week of life, it will become more obvious. You have many very small yellow papules that are over the nose and the upper lip. This is the most common area, and most times it will go away on its own after a few weeks of life. Don't need to treat. Okay, don't need to treat. You can reassure parents that this will go away after a few weeks, or at most 1 to 2 months. Okay, so don't need to treat these patients. Okay, occasionally we are called to the ward, neonatal ward, to see a patient with this. You can see that there's like erosions, maybe a blister there. Yeah, you can see a very superficial erosion, and usually it's at the point where the baby can suck. Yeah, on the lip, on the hands. I've even seen it on the feet because they curl up in the mummy's tummy, right? So they can see it on the feet as well. So what's your diagnosis here? This is sucking blister. Not so common, but sometimes they call us to see these patients, yeah, the neonatologists. So it's due to the sucking when a baby is inside the mummy's tummy. It is fairly common, but we usually, when we are called to see these patients, they are very concerned about this condition called epidermolysis bullosa. All right. So some of the mild epidermolysis bullosa, I'll talk about EB later on in my next lecture. But it can sometimes present with blisters at birth. Again, you can see here this baby with, you can see a blister there and a blister here, but this is all where the baby can suck. Yeah, on the hands, on the lip, sometimes on the wrist, on the fingers, and sometimes rarely on the feet as well. All right. And sometimes, as I said, maybe at the distant site on the feet as well. Okay, but babies otherwise very well. So the differential diagnosis, again, you have to think of impetigo. So if you see more blisters coming up and baby has some fever, the area there looks a bit more annular with this annular rash, you have to think of bullous impetigo. Again, if you see intact blisters, you think of herpes, especially a baby unwell. But differential, if they get more blisters, is epidermolysis bullosa. I'll talk about this in my lecture on the genodermatosis. Okay, I got 2 more cases. This one, again, quite common. This is a 2-week-old, so a little bit older. They get this mostly on the body, but sometimes you can see on the limbs as well. You can see this very small papules. Sometimes you may see pustules as well. And then sometimes the baby may have fever, or sometimes the parents will wrap the baby up and the weather is very hot. Yeah, so you can see this. This malaria or heat rash. I think we have a lecture on malaria later, so I won't talk too much about this. Okay, this is caused by the immature sweat glands, and then the sweat gets stuck inside, and usually it's because the parents will wrap up and it's very hot weather, and you can get this malaria. There are two forms. There's actually a third form which is less common, but the two common forms are malaria crystallina, where you see very small, superficial, very pinpoint vesicles, or malaria rubra, which is seen here. You can see a little bit more small little red papules, usually over the truncal area, because that's where the baby is wrapped up. Okay, so you can leave these alone. Generally, the differentials would be erythema toxicum and infections, but baby is otherwise very well. So in malaria, okay, important, babies are very well. So to treat, you want to avoid, tell the parents, don't wrap up. Yeah, don't wrap too tight, don't wear too many layers of clothes, use very light cotton clothing. You can use a little bit of cool baths to help with the cooling as well. And don't use too strong emollients or moisturizers, because it can cause worsening of the malaria. Sometimes a little bit red, baby's a bit distressed, you can give a little bit of mild topical steroids, but generally it will go away on its own once you stop wrapping baby up too much, all right? Okay, and this is the last case, again, very common that we see, usually starts at a few weeks of life, 3 to 4 weeks. You can see these little red bumps. Sometimes they might be a bit scaly, and it's usually on the face. Sometimes you can see pustules, but you do not see comedones. So you don't see any black heads or white heads. Yeah. So you see mainly papules, red papules, and sometimes pustules as well. Yeah. So this is neonatal acne. Okay, again, it is quite common, and we see it, I usually see it sometimes with babies who also have seborrheic dermatitis, all right? So this again occurs because baby gets the hormones from the mother when baby's in the tummy, and that can make the sebaceous glands a little bit more active, and then they may get co-infection with Pityrosporum or Malassezia, and it can trigger this neonatal acne. Importantly, they present with small monomorphic papulopustules, so they do not have comedones, no black heads and white heads. All right, you see it mostly on the cheeks and the forehead. This is one of my girls when she was a little baby, and you can see this is more severe. Yeah, all right, and you can see it. More pustules as well, all right? Very often they also have seborrheic dermatitis, because seborrheic dermatitis in babies sometimes can also be driven by this maternal hormonal stimulation as well as the Pityrosporum. Again, it self-resolves once baby gets rid of the maternal hormones. This neonatal acne will go away, but sometimes can go on for 4 to 5 months, and it doesn't scar. Okay, so it doesn't scar. Treatment, if it's quite mild, you can leave it alone and then it does get better. But if it's more extensive, what I like to do is to give a bit of antifungal wash, like ketoconazole. You can add on a mild anti-inflammatory medication. My favorite is Desowen or Desonide. And sometimes we use and can put on some moisturizers. I like this moisturizer called Sepclair, which has a bit of antifungal, and you can treat that as well. But importantly, it does go away after some time, and you can leave it alone, and you can reassure parents that there will be no scarring. Okay. So I've shown you all 10 cases of physiological skin changes, which are very common in babies, and a lot of times you don't have to treat, but important is to see whether baby is very well. All right, so if they're very well, then you don't have to be too worried. Okay, so important to recognize these conditions because it's very common. Okay, so but always consider to exclude other more dangerous conditions like infections. So if baby is unwell, fever, you have to think of infections. Or if it doesn't follow the usual timeline, that means you expect it to go away, but then it's still there, you have to think of other conditions. Okay. So finally, I'd like to thank you for this first lecture. I hope if there are any questions, we will take it later or now. Later? Later, all right. Okay. So once again, thank you for your kind attention. I hope that I've been able to teach you a little bit about physiological skin changes in the neonate. Thank you.
Thank you. Thank you. Your very interesting presentation. Thank you, Professor Mark. Thì vừa rồi giáo sư Mark đã trình bày rất là nhiều các biểu hiện của da trẻ sơ sinh mà nó thuộc về các thay đổi về liên quan đến sinh lý hoặc là những cái tác động nhẹ từ bên ngoài và đa số là không có cần điều trị. Những biểu hiện này cũng rất là thường gặp, tuy nhiên là chẩn đoán đôi khi là chúng ta cũng gặp lúng túng. Thì bài trình bày kế tiếp thì là của giáo sư Leon Kinfong về những cái bệnh lý da trẻ sơ sinh và các